Conversations in Frailty, the podcast for Derbyshire clinicians.
Welcome to another episode of Conversations in Frailty, and today there's been some interest in a topic of safeguarding, and so I'm discussing the topic specifically of self-neglect in our frail elderly population. I was really delighted to find somebody who wore both a safeguarding hat and a frailty hat, Dr Amy Lampard, who will introduce herself and her roles, and really enjoyed the chat I had with her, and lots to share with you from that. She was able to give some very practical advice about how to try to get a bit of clarity about the risks involved when we go out to see a patient and have that niggling feeling that we should be raising a safeguarding concern, and actually also tips around documentation and even some really sort of quite specific summary phrases that she uses in her documentation that I found really helpful. We talk about all sorts, and another area that's useful is those patients who appear to talk the talk but not walk the walk. So multiple people have assessed that they seem to have decisional capacity, but actually they don't follow it through and they continue to neglect themselves. And how do we document this and handle those sorts of cases? Anyway, lots more in there. Enjoy this podcast, and I'll be back at the end with a few summary learning points. So, I'm here with Dr Amy Lampard this morning, and for the listeners, can you just introduce yourselves, tell us a little bit about what you do and what your roles are relating to frailty and safeguarding?
My name's Amy Lampard. I'm a GP by background, but I've managed to get into a much more interesting area of lead community GP for the Ageing Well team in Chesterfield. I also am the designated doctor for adult safeguarding, Sheffield Place, South Yorkshire ICB, which I'm surprised I've managed to remember the full title, but basically providing support and education about safeguarding for GPs. So the two roles actually fit in really nicely together, and I do very much enjoy them, but I'd much rather be sewing and making clothes and crafting around.
I'm here today admiring Amy's beautiful dress that she made. So, yeah. Lovely. So I think for the listeners out there, and we have a range of listeners, just a reminder for us all about the concept of safeguarding itself. And actually we decided today to focus on self-neglect because it's such a huge topic, even in older adults. So talk us through your sort of, in your head, your definitions of those.
So I think a lot of the time we think about safeguarding as, oh crikey, something needs to be done for this person. But if we take it back to its real roots, it's safeguarding a person's human right to life. And that's really useful when we come later to talk about sharing information, because that right to life is absolute. So we can share information without their consent, because otherwise they could die. And that is all about human rights. So safeguarding is when we recognise risks to a person that they can't protect themselves from for whatever reason, especially if that is a health related reason. For instance, somebody has dementia or learning disabilities, or they use a wheelchair, or are in a domestically abusive relationship. We can use that language if they can't protect themselves from harm in order to be able to help and refer and get some more support for that person. And that's what safeguarding is meant to do. It's about getting the support for that person to reduce their risks of harm.
That's nice, because it turns it into a more positive thing, actually, I think.
Definitely. Yeah. And it also reminds you this is a referral destination. We are still involved, especially as GPs, because there are patients now and probably forever. We've got to maintain a relationship, and I think that concept of getting more support for people is really useful. And I think when we're talking about self-neglect, the source of harm is that person themselves, but there will be reasons why they're unable or making unwise decisions that lead to their harm. So this kind of work, you do have to be quite nosy. You have to ask people those questions like, but can you do that? And what does this mean you can't do? And why is it that you're not doing that? Why is it that you won't go to the hospital for that appointment? And you can find out some really interesting things like, actually, it's transport and I can't get there. Or I'm an alcoholic, so I'm drunk by 4 p.m. Or I've got kids and I've got to get them to school, so I can't make a 9 a.m. appointment. You know, this all blends into reasonable adjustments.
And is that nosiness what we might term professional curiosity, if we like to give it a good name?
Definitely. that is the new label. And I think we get beaten up by the phrase professional curiosity without people perhaps understanding that as GPs we're in that unique setting of having to maintain a relationship whilst finding things out. And I think if you can explain to somebody why you need to know, I'm not just getting gossip, I'm not just going to chat about it, it's because I need to work out what support I could offer and why things are difficult for you. And often just sort of asking people about their home situation. How do you manage this? How do you manage that? It is amazing what people can hide their home situations and struggles behind a very well put together external appearance. And I think that professional curiosity is really hard to document sometimes, to document that you've asked. But that, if you can find a turn of phrase of your own, that's quite useful.
That's helpful. Yeah. And in terms of responsibility, I think we all, it's been drummed into us, safeguarding is everybody's responsibility. But I just thought, as a question to spin, and some of our listeners, for example, might be working in a frailty team, might be a GP. What should we be doing when we get that piece of information from a concerned carer, maybe in a care setting, or a concerned district nurse saying, I'm worried about self-neglecting this patient, can you raise a safeguarding concern? What would you advise us in that scenario?
So I firmly believe in he who smelt it dealt it. So do it yourself. If you see it, you do it. If there's two concerns going in about the same thing, brilliant.
Yeah.
Brilliant. We're actually raising that awareness. I think it is reasonable if you come along and you find a patient and you know that district nurses are involved and you're wondering if they've raised a concern, why not phone the safeguarding number and ask, are you aware of this person? Save yourself writing the form.
Yeah.
But you may have fresh information, historic information, family contacts that the team might need that you could add to it. But I think if a district nurse asked me to raise a concern on their behalf, I would direct them to their own safeguarding team and leads within their team. That every team will have a safeguarding lead.
Yeah.
Go and ask them.
So it's not coming sort of third hand or something.
Yeah, exactly. Yeah. It's your concerns, you're the one that's seen it. We might be able to say we can support, but I think ultimately it's the person that's seen it who needs to raise that concern.
Fine. And I think one of the key areas we wanted to have a brief chat about was capacity assessment and documentation. Yes. And I think you had some tips around that for us. So
I think that assessing capacity has become this massive thing that people are not sure about, and I think it's the documentation that's really important. So my kind of top tips are, with capacity, we're meant to assume that they've got it. We've got to provide them good support and help people if they want to make unwise decisions. But essentially, define the question. What is it that we need to know? What is the decision that needs to be made? And are we the person, are we the decision maker if this person lacks capacity? So if it's to do with where they live, that's not us, that's a social worker. If it's whether or not this person should be peg fed, well, I don't put in a peg, so I'm going to ask for a gastro consultant to be involved with that one. Let's say it's about, should this person start an antidepressant? That's my bag. That's us. So I've got my question, I've got my kind of, or it might even be 2-week wait referral for anemia. in somebody who's very elderly, very frail. And I'm thinking about what are the risks, what are the concerns, the pros, the cons, what are the other options. So with all of these, you will have what the patient wants to do, what you want to do. There might be something in between.
Some compromise.
So especially with anemia, you've got patients who will say, I just don't want anything. And we want a 2-week wait, scope, up, down, everywhere. Right, what else have we got to offer? How about monitoring blood tests? How about a CT scan instead? How about discussing with the patient, probably with family support or their advocate support there? So when you're then talking to them, you're explaining the risks and you're asking them to weigh them up, consider them and demonstrate that they've understood what risk they're taking on, you've got that support there. So if they do lack capacity, you've had a best interest meeting because you can discuss it then with their lasting power of attorney or their very supportive daughter, neighbour, whoever, about the situation. You don't have to redo it.
So you're already moving on to that
next
moving. Step, aren't you?
You're going to come away with your decision.
Yeah.
And the point with unwise decisions is they're still taking risks and they're still your patient. You can't just say, bye, Mr. Smith, off you go. No, you need to think, well, what's the plan? Is there any risk reduction that I can do? Is there anything else that I can think of? So rather than saying, he doesn't want to go for a 2-week wait, end of, we're thinking about, well, what actually might we need to do to see whether things are getting worse? Okay, might not want to go and have a transfusion, but what about an iron infusion instead? What are the other options for this person? Discuss it at that same time. I often say if you've got an awkward decision, an awkward patient or an awkward family, get out your proper documentation and before you go, write out the different options, the pros and the cons of each, what are the risks, and then you can write down comments and quotes, hopefully a really useful one for the patient. My favourite being when I was discussing choking risk with a chap, and he went, oh no love, there's no pork sandwich worth dying over. I thought, brilliant, you've understood.
Yeah.
You eat that sandwich, you choke, you die. And that was my quote, and I was like, brilliant. Thank you for that,
It really gets their vision of what's going on, doesn't it?
It does. Yeah. And it also means that when you write that in the notes, you can say, and what I often do is say, regarding the following decision, I have explained the following risks. The patient named Beryl has understood and accepted the risks of not proceeding with my advice. So it's the risk. What have you actually said?
Yeah.
Because then later on somebody else could say, well, actually, we didn't offer them this. Maybe we could do that. But it also is saying exactly what you said without being too laborious and pedantic about it. I also wanted to talk a little about the executive function.
Yes, I think that would be really helpful.
This is the new word on the block. Like professional curiosity, it's a label for something that we've known a long time. We've got patients who can talk the talk. They talk the talk, they have capacity assessments. This is what we'll argue with other professionals about, whether or not they've got capacity for a particular decision. And you'll be like, oh, but I know over the last 5 years, they've said they'll do that, but they don't.
Yeah.
Because they can talk the talk, but they won't walk the walk. They've got decisional capacity.
Yeah.
So they can make the decision, but performative, they can't put it into action.
Okay.
So you've still got somebody who's taking loads of risks. We haven't adapted the risk because we think, well, they've got capacity. So that's where I think it's really important.
So would you document that as they have capacity to make the decision, but then say not functional follow through?
I would definitely say, although this patient can demonstrate an understanding of the decisions, they have been unable in the past to implement things that reduce their risk of harm. I therefore feel that they lack capacity, especially executive capacity.
That's really helpful. I think I'm going to be writing that phrase down.
Get it in
Make
your
a shortcut.
But it's the new buzzword.
Yeah.
So definitely, if you're having an argument with another professional about somebody's capacity, ask them or provide them with the evidence that we've been around this rodeo. We've done this 6 times before. And then my next thought is multi-agency. But that probably brings us on to talking more about self-neglect.
Okay, yeah. So we thought we'd bring this to life by thinking actually just through a obviously anonymised case that you've been involved with, which you might embellish as needed. So just describe it for us and we can work it through.
So I think one that a lot of us all have recognise is a person who is not particularly elderly, let's say 70s, living alone, often male, in a house with really poor hygiene levels, both of themselves and of their environment, with leg ulcers or a vascular leg issue, and we're looking at that. The district nurses are getting really worried that this patient's going to die of sepsis and we're not doing anything and they won't do this. And we've been round this a few times. You've given the antibiotics, you've had an argument about whether or not they should go into hospital, and we're back again. We're back again.
Sounds familiar.
And we go into the house and it's smelly and there's food on the side and this person is not looking after themselves very well. They've got poor hygiene, they've got this acute issue with the leg, and we're left with this kind of, they're self-neglecting, I want safeguarding involved. So, press pause in your minds. What are the risks that we're worried about? Let's start with the leg. We're worried about sepsis.
Yep.
Sepsis leads to death. High level of harm, high level of this actually happening. They're the 2 things to have in your mind. Think of the risk, think of the likeliness of it happening, and think of the level of harm. Yep. And if it could be life-altering or death, we're starting to think, crikey, we might be able to discuss this under a safeguarding umbrella. We need multi-agency, and we're going to need to, we need to do this to save their life, basically. So we're thinking about these different risks. What are the risks to the person? We've got the leg. The lack of hygiene. Well, the lack of hygiene has probably led to increased chance of fungal infections, increased chance of infection in that wound. What are the risks? What are the likelihoods? Next bit, what about the environment that he's in? Is he actually eating properly? That mouldy food could lead to gastric infections. We're into an even worse situation. That dog that's pooing all over the place, or the free flying parrot we had to deal with once, pooing everywhere. Yeah, you're right, that's not great. The hoarded stuff all over the place. High risk of vermin. Vermin bring disease. Disease, open wounds, death. That's my risk from the hoarding. The other problem with hoarding is that it means that you can't access different areas of your home. Can you actually get to the toilet? Or is that why you're having to go in a bucket? Can they get to the kitchen? Or are they having to get in takeaways because they can't get to their stuff?
I guess fire risk as well, potentially.
Exactly. Yeah. Fire risk and collapse of stuff onto the patient. That is a real life situation, or real death situation. So the risks, identify those risks, and then just take it down the bad route. Those thoughts, extrapolate out. Because if we're getting lots of things where this person is at high risk of harm, and then we're talking to them and they understand those risks and they're saying that I'm happy to accept those risks and it's my right to make an unwise decision. It is. But how much of that behaviour is influenced by other situations about mental health? We know that with hoarding, that's now on the mental health diagnoses that is recognised. So we do need to be quite challenging with these patients, identifying those, and that's what needs to go on the safeguarding concern form. You're raising your concerns about all of these things. And then we need to think about what is it that we want to achieve.
Yeah.
We probably need to know from the fire service, from the district nurses, from anybody that's involved with this person, maybe housing if it's not their own home. We probably need all of those people to sit down for a meeting. And actually, under the safeguarding umbrella, that might be called a VAR meeting, Vulnerable Adult Risk Management Model. It might be called something else. There's lots of team around the person. There's lots. Each area has its own thing, but essentially you're wanting a multi-agency, not multidisciplinary, because we tend to do really well at getting health involved, but we don't tend to think about the other agencies.
The wider picture, yeah.
Fire service, definitely. Yeah. And although the patient themselves may say, I'm not at risk of fire, what about other people? What about their next door neighbours? The next door neighbours will be complaining about the rubbish and the vermin risk.
Yeah.
Is there anything that needs to be done to protect other people? In that household, is there another person? Is there an elderly spouse? Is there a child who can't protect themselves from harm? Is it an adult child with other difficulties? So we need to just sort of think about those people as well. So you identify the risk for the person and what might be done about them. You identify the risk for the other people in the household and what's needed with that. And unfortunately, that may mean more safeguarding concerns.
So you would do an individual one for each relevant person, wouldn't you? Yeah.
But link it as a household. Yeah. Think about the animals in the household. You might need to raise issues with, the Animal Protection Society places. Yeah. What about for the public? If you've got somebody who is got this big fire risk, that's a public issue as well. All the different services that we've mentioned, places like the fire service, are really good at offering risk reduction things. Things like if you've got somebody who's smoking in bed, fire retardant duvets, sprinkler systems, all free.
Brilliant.
But what if they say, no, I'm not letting that fireman in my house? They will actually go around the neighbours and protect the neighbours around that house, especially if it's a flat. So the risk to the public, to other people, is therefore reduced. So it's still worth it.
Yeah.
It's still worth raising that concern. So as we're raising our concern, and we've listed all these risks out, and we're really saying, I think we need to have a big discussion about this person. And the idea of the VAR meetings and safeguarding is let's produce an action plan and allocate those actions to specific agencies and people. The VAR meetings and the matrix that we do, and I've mentioned the likelihood of risk and the seriousness of the risk.
Yeah.
All that does is gives you a number to give you a recommendation of how urgently you need to act. So if it's something where there's a high risk of harm and it's really likely to happen, that next meeting to get those actions done by might be a week away.
Yeah.
Now, I'm already overwhelming everybody with the thought of doing this massive assessment, of doing meetings. But I would say this is one situation where it's best to be a diva and say, I'm the GP, I work these days, I can do 1 hour for the first meeting at this time at this place. Can we do it on Teams? Do you want to come to our practice and set out your stall? Is quite useful to be the lead on the action plan as well. Even though we'd much rather the safeguarding team just took it all on, I would rather be in control of when they're going to ask me to come and do something.
And if you're listening to this as, say, an ACP within a frailty team, who would you recommend going to the VARM?
I would definitely talk to your safeguarding lead for your team.
Yeah.
Or for the lead for DCHS or wherever you're working for. Talk to them And what they will then do is help you decide whether it's you who needs to go. It normally is a practitioner level event.
Yeah.
Sometimes you need managers there to make the big decisions, like especially with social work, it's about additional funding and things like that. But I think if I was an AMP and doing raising a safeguarding concern, I would talk through with the safeguarding lead.
That sounds
because
sensible.
you need that support and you need that second pair of eyes, that second opinion.
Yeah.
The other thing that's really useful is to think about what risk assessments might be needed. So we know about like Waterloo scores and must scores, but how about the clutter index? Now this is my absolute favourite risk assessment. It is easy to find on the internet. We put in clutter index hoarding.
Yep.
And there are 9 pictures of a different room, so of a living room, going from 1, scoring 1, which is absolutely obsessively tidy, your mother-in-law's coming to see you, all the way through like normal living, teenage bedroom, all the way up to number 9, which is really very hoarded, very risky.
Risk of collapse kind of level. Yeah.
If you go to somebody's house and level 7, 8 or 9, so you really are looking at quite high risk of harm to that person living there, that's when I would be raising a safeguarding concern based just on the hoarding
alone. That's helpful.
Because of the risk.
Yeah.
So grab those forms out. And if you get somebody like a district nurse saying, oh, it's ever so cluttered, I didn't like it, tell them, put me a number on it.
Give me a number. Just to quantify it a bit.
Because my level of hoarding, as you can see from my house, is very different to somebody else's level of hoarding.
I'm worrying now because my mother-in-law is actually turning up later today. So I'm not at a level 1 yet.
So really, I think with all of these self-neglect, with any kind of capacity decisions, you're looking at risk. What is the risk? What is making me so worried about this patient? And it's normally the flippant thing that you say when you get back in, like, oh my gosh, you should have seen it. There was parrot poo everywhere. Right, that's the thought. Where does that need to go? And also, has this person engaged with trying to reduce any of this risk before? And you might find, well, actually, they are engaging really well with lots of agencies. Maybe we need to give this a bit more time. And that's definitely a discussion with your safeguarding lead. And they might actually want to discuss it with the local authority safeguarding teams and say, this is where we're at. We're not quite ready to raise a concern. Do you know if anybody else has got concerns?
Just get the bigger picture.
The bigger picture. Yeah. And it's that engagement and finding somebody who's engaging with that patient. Somebody's buying the alcohol, the cigarettes, the food. Somebody's looking after that dog. Who do they know? And they might be quite useful. We haven't talked about reasonable adjustments, but essentially they're just all the things that we do when you're going above and beyond with that. It's understanding what time of day, what place, what people does this person respond well to. And
so to maximise our chance of interacting well with them. And
How do we maintain our relationship? GPs have done it for years. They'd be the ones where you always went round last thing. It was always your last visit. Or it's the ones where you go and see them at the allotment. Or one nurse had consultations in her car. District nurse is doing bandages on the front lawn because he couldn't stand you being in his house. So. But then you have to ask why. That's your professional curiosity coming back in. What is it that you won't do? What is it that you can do? Anyway, that's lots of talking. I hope I've made sense.
But there's lots. I think there's lots to pick out there. I'll come back to some of that when I reflect at the end. So so we've talked through all this and the nitty gritty of actually, we're going to make the referral. Would you always recommend speaking to somebody or speaking and completing a form? What would be your advice?
So I'm going to be really pernickety. We're not doing a referral when raising a concern.
Okay.
Let's get with the lingo.
Yeah.
Because raising a concern makes you think, I'm setting up a flag, but I'm still holding that flag.
You're not passing the baton on. Yes.
You're still holding that responsibility, which we don't want to. And as GPs, I think we often feel left with that. But what I would do is I would sit down, write out my risks as bullet points, write out why that's a problem. The vermin, it's that open wound that I'm worried about getting infected. The not clearing up, the not using the toilet, it's falls risk. Write that out. Then I would get on the phone and I would try and make that phone call if you can. Okay. Now, that's not always an option because we work for the hours getting all our work done. But I would definitely try and phone, because then you can have an immediate, you can express your level of concern.
Yeah.
And you can really ask immediately, why do you think that doesn't need looking into? I think this, and this. And I think from doing that, you can actually be quite open and say, what I really need is help to get them this. If I was dreaming, I would get one-to-one care for this patient. Or if I was dreaming, this wife, it's care of stress that we've got here. We really need to do an urgent assessment, maybe respite. We're going to end up in a real pickle with this if we don't. Having that conversation is much easier, but then back it up with your concern form. And if you're feeling very pedantic, pop a little bit from our conversation earlier. My understanding is that we agreed, blah, blah, blah. We agreed that you would arrange this assessment, that I would share information regarding diagnoses.
I think that's helpful, actually, and with you saying sort of what, in an ideal world, where would we go with this? I think if we've got to know a patient a bit, actually having that concept of what might be the least restrictive thing for them is really nice to be able to pass on as well, isn't it? Because it's that vision of actually this is how I think this person might like to be, and that's something a bit softer sometimes.
And I think that's what we want, is it? We want what is best for the patient. We want what they want. We need to reduce some of those risks whilst respecting it. We will have all had patients where they are making decisions to not only risk their life, they're risking our professional registration. And we're there thinking, you're going to take me to the blinking coroner's court, you are. Right, we're having that thought, share it.
Yeah.
Share it. Let's get people round the table all to say, eek. Now, if you're having those kind of discussions and you're worried about, like, this patient wants to die at home, they've got an option where they could live, can we leave that, can we not? First of all, talk to your own safeguarding leads, ask them to help you escalate it to the ICB. Because there are things like the court of protection, which may need to be discussed with. It's about the legalities, back to the human right to life. So taking it all the way back to there.
And I was going to say to you today, how do different teams refer? But I think the bottom line is all teams will have a safeguarding lead within them. So it's a case of make sure you know. If you don't know at this time you're listening to this, find out who is your safeguarding lead, so that in that situation you'll pass it to them and they can take it forward.
And actually that also helps your safeguarding lead think about further education for the team. What updates do we need? But essentially there'll be a number. If you're in Derbyshire, call Derbyshire. You look at that, you go to the safeguarding for your local authority, they will have information as well. And you can challenge. So if something has been raised as a concern and then you find that nothing's happened, nothing in brackets, actually you can go back and say, why not?
What's happening?
What's happening? Why didn't you take my concerns seriously? It's how we feel. And then you get the answers. Or you can say, no, you misunderstood. What I wanted was this for this patient.
Did I not quite get my message across correctly?
And if you're still hitting a blank, that's when you talk to your safeguarding lead and they will talk to the ICB and we'll have discussions that way. And sometimes things need to be escalated way above our heads.
Great. Well, I think there's so much more we could keep going on, but I think we better draw it to a close for today. I will just flag up with the mentioning education. I know the Adult Safeguarding Board has a good self-neglect toolkit as well, isn't it? So that's a good place people can go looking.
Yeah, really
for
helpful
more
for
written advice.
Yeah.
Brilliant. Well, thank you ever so much for talking to us today, Dr Lampard. I'm sure there's lots of useful stuff there for the listeners.
I hope so.
Thank you. What a great conversation that one was. Trying to come to a sort of short list of useful learning objectives. I suppose I've narrowed it down to one around sort of the concept of what the point of safeguarding and our role in it is. And then secondly, the questions we should be asking ourselves when we're in a situation that we're concerned about. So the first one, I think Dr Lampard really got to the sort of crux of actually what safeguarding is really about for us. It's not about making referral and handing on the baton. It's much more, the focus should be around actually we're raising a concern, we've recognised someone can't protect themselves from harm, we're sharing this to involve others, but we're not losing the responsibility there. And I think that's really important, that we still need to be working on risk reduction throughout. So, for example, if we have a patient who makes an unwise decision about an admission to hospital, we don't simply assess capacity and document that, but that we actually think about how we can reduce the risk of further harm within the situation they've chosen to be in. And then in terms of the clarity about what risks are involved and the questions, I suppose, sort of reducing it down, her key questions really were, actually, what are you really worried about? How likely is that? And what level of harm is involved? And how much of that behaviour is actually influenced by mental health issues, which can include hoarding? And then finally, what are we actually trying to achieve here if we do some blue sky thinking? And that may well be around getting not just multidisciplinary medical input, but actually that multi-agency input in. Now, for the first time, I'm going to actually add some show notes to the episodes in the comments, and I think there's obviously the Derbyshire Adult Safeguarding Board website is a great place to turn, and that has a self-neglect toolkit within it. So I was going to include that, as well as the clutter index for any of you who are not familiar with that. And finally, a link that Dr Lampard recommended to an excellent video giving a personal viewpoint on the impact of hoarding. It's a long YouTube video, but even the first 3 minutes, I think, give you a really patient-centred insight that's well worth having a look at. So those come highly recommended as well. Thank you as ever for listening in. Do keep giving feedback and making any suggestions to any topics you'd like me to include in future. I'm sure Dr Lampard and I are likely to find another safeguarding topic at some point that we would be able to discuss again that's relevant to frailty. But in the meantime, hope you've enjoyed this episode. Spread the word, and I'll look forward to your company for the next conversation in frailty.
Conversations in Frailty. Thanks for listening.